Good morning, everyone. It's pretty exciting to be here. I remember the year ago conversation about this idea, so here we are. We've heard a lot to be energized about already, and this panel is technically the first full panel of the day is to discuss why gender matters in health, workforce, and leadership. And so as I was listening this morning, I was just thinking about what, we all have a lot of big ideas, hopefully, as we've heard, to come out of this, but also why we do this work. We do this work, I think a common thread would be we all want to change the world. That sounds very lofty, but I know that's what motivated me. So I hope at the end of the day, we all still feel that way. But in a small way, for those of you who are earlier in your careers, I hope today instills optimism. And I say that because I work and live in Washington, D.C., and I do health policy. And I'm a very optimistic person, and my optimism is being tested. And I'm here today to hopefully gain more of that optimism. And I'm remembering what motivated me when I first got involved in global health and health, and what was it that drove me. And it was the early days of the AIDS epidemic and a real feeling of desperation, and that what existed was not working, and that change had to come, and we didn't know what that was. And I remember that now because it was a different time and different circumstances, but one where there was not a clear path. And I think a lot of energy, communication, and women, frankly, coming together with new ways of looking at things did create a new path. One which I think is, in a way, very responsible for creating a global health movement that we have today. So I think it can be done. And I hope all of you out there will do it for us, too. So let me tell you who we have here today. We have four global health leaders who will share with us a little bit about their perspectives on this question. And hopefully you'll hear from them a little bit more about who they are and why they do this work, although I think it'll be clear in their remarks. So let me just tell you who we have very briefly. We have Veronica Magar, who's the team leader for gender, equity, and human rights at the WHO. Hello. We have Harriet Mayanja, who is the former dean of the School of Medicine at Makerere University in Uganda. Hello. We have Glenda Gray, who is the president of the South African Medical Research Council. And finally, we have Afaf, Meleis, who's the dean of nursing Emeritus at UPenn. So I'm going to, great leaders here. So I'm going to ask them each a question to get us started, and we'll have time for going back and forth a little bit. We have 30 minutes, minus maybe a little bit because we're behind schedule. And then we'll go to your questions. And for those who are watching, please send questions in. I have what you're supposed to do. Start with a cue so we know it's a question. And I can't read this because I don't have my glasses on. So just please send your questions in. Okay, so I'm going to start with Veronica. From WHO. And we've heard a lot about WHO today, but also for those of us following and excited about what we've heard. And so I thought since she was on our panel and is coming from WHO, she could tell us a little bit about what has just happened there in terms of leadership change. What's the vision as she sees it? And also, her role is to really think about gender as it interfaces with human rights and how that should inform the WHO agenda. So, Veronica, welcome.
Well, it's certainly a delight to talk about this and to talk about this with so many friends. So what I'd like to do is start with a quote from our new Director General, Dr. Ted Ross. It's a popular retweeted statement. Gender parity is possible if we are prepared to admit that there are talented women around us. Problem is that we don't admit that they exist. Now, this is leadership. I think we've reached a huge milestone, as you have seen. Our Director General is sending a clear message. I think our Director General is our friend. And I say our Director General because I think he doesn't just belong to WHO. I think he's the people's Director General. He belongs to all of us, and the world implores this kind of leadership. And this is something we need to do together. So 64% of senior most leadership at WHO consists of women, representing the 6 regions of WHO and 14 countries. So this constellation actually makes way for an ambitious vision. And there are actually, to respond to my sister Agnes, there are big plans for the second layers. So what is our vision? I think his number one vision is to ensure universal health coverage. That means individuals and communities have access to quality health services. Does this sound familiar? This is an old goal that we've had globally without financial hardships. So what do we need? We need what's starting to emerge here. We need a global movement around this. We need a collective vision. We need a broad-based coalition with women in all of our diversity to be at the helm. We need empowered, embodied, diverse women leaders in the health workforce, from the lowest level of community health workers that are unrecognized, undervalued, unpaid workers, many of them in this room, and often unrecognized people at the senior most levels of our institutions. I think our time has come. So why does universal health coverage matter so much? Out-of-pocket payment or health spending drives more than 100 million people into poverty. Women are disproportionately affected by this. Women borrow and they sell assets, not only for their own health care, sometimes last for their own health care, for themselves and their children, but often distant uncles several villages away. So universal health coverage actually has the potential to help women from multiply marginalized groups. We need to ask questions like, how far does this burden fall disproportionately on one sex? So in sum, WHO's vision is to ensure that no one is left behind. UHC is centerfold to that end. We need a movement. We need a collective vision in which we all share a stake, and women need to lead this.
Thank you. And congratulations to WHO for taking the step. So now I'm going to turn to Harriet, who, as I mentioned, is the former dean of the School of Medicine, and also I know very involved in global health education and working with students and what that means in terms of shaping them as future leaders, women and men. So will you tell us a little bit about that and how you've tried to incorporate the issues of gender in that education and in the work that your university has been doing?
Thank you, Jennifer. First of all, I'll take a step back. I'll take a step back. When God or evolution or nature made the world, half the people were born as women and half of them were born as men. So already evolution knew that we need both men and women to move society. But we have to realize that over time, there are social expectations of men and women, there are cultural differences, there are behavior differences, and of course, there are biological ones. Now, when it came to healthcare in Uganda, most of the healthcare in Uganda is done by women. I work on the medical wards, and we know that once a patient is admitted on a medical ward without an attendant, that patient won't survive, and it's usually true. And usually the attendant is the woman, not the man. Some women say, do you know, I think it's always better for the wife to outlive the husband, because when the husband is sick, the wife will look after him. But when the wife is sick, she has to look for a sister or an aunt or somebody to look after them. Mm-hmm. Yet when it came to medical school, admission in medical school was mainly men, not by choice, but by many factors. When I went to medical school, I was told, that course is long. 5 years, won't you get married? I mean, you could have done something that is more womanly than manly. So in my days, about 8% of admissions were women, now about 30% in medical school. Our university and our government has gone forward to look at affirmative action. Women in Uganda are given an extra points to get into university, 1.5 points. People have disagreed with them. This is unfair. What about the boy child? When do you need this? Why do women need help to get there? But they don't realize that women don't need help to get there, but women have too many things pulling them down. In Uganda, nearly every child starts school at the age of 6 years. About 90% start school. By the age of 12, half the girls have dropped out, and the men have continued. So the girls who make it to medical school are those who have to work harder, who have to fight harder, who have to scream harder. Many teachers tell women that, women don't do sciences. It's men who should do sciences. So the girl who gets into medical school, it's even higher, harder to get there. And once there, things are not always easy. When we were in medical school years ago, there was this young man who once kind of pushed me aside and said, hey, you girls, I think all girls should be nurses in the hospital, but with a doctor's pay. I mean, you are in the wrong profession. I remembered that statement, and when I became a leader, when I was in Senate in our university, we came up with a regulation that let's try to aim at 30-70. In nursing school, let's try to have 30% men. Engineering school, let's try to have 30% women. So we're working towards that. And now in medical school, we have about 30% women and 70% men. Not ideal, but we are getting there. And then we always remind our students, people, that, do you know, we need both men and women. In my country, many women have names starting with N-A, na somebody, the feminine of the man. So when we put them in alphabetical order, all the women are clumped together. So when we used to put them in groups, you'd find one group has only women, others men. So now we changed it around. We go 1, 2, 3, 4, 1, 2, 3, 4. And we try to make sure that every medical student group has both men and women. It's interesting, and I tell the boys that, you know, your group would be dull without the women. And I tell the girls, your group is more exciting with the men. So each one pulls the other one along. And over time, much as you have made a lot of changes, there are still challenges facing especially the women, especially as they go higher and higher. When they join medical school, it's easier. They are all 18 years, they finish medical school at 23 years, they're young, unmarried, looking for relationships, life is easy. Then they go to graduate school, M.Med, at the age of 28, 30. The girls are either married, have children, and so on. The men are also married and children. The men can look after their babies without anybody knowing they have babies. The women have to be seen big and fat and round and so on. And I noted over time that the women need a little more support than men. I'll give you a few stories. This girl, Elizabeth, was doing her master's, and on Monday she had a cesarean section. On Thursday, she came to the office holding her tummy. Professor Mayanja, I'm coming next Monday to do the clinic exams because we're in exam season. I told her, Elizabeth, go. But if I don't do it, that means I lose a semester and have to repeat. I said, no. I'm the chair of medicine. I've decided, go home, come back after 2 weeks, and you'll do that exam. And I'll get examiners and you'll pass. And that's what she did because she was bright. She wasn't stupid. But just because she had a child doesn't mean she stays behind. More recently, this girl was about to start her master's in medicine, and she was heavily pregnant. So I said, when are you delivering? I'm having a cesarean in August. When do you start college? I start in August. How will you manage? Oh, I have a young helper. So I'm going to take my baby, put her in the car with the helper, park under a tree, attend class. Then in between, go and feed the baby. Then I said, what if the helper wants to go to the toilet? He said, I hadn't thought of that. So these are things we have to look at. And we as leaders have to look at both men and women and look at their needs and try to address them and try to help them grow up together, each one in their own way, but each one supporting the other.
Great, thank you. And thanks for the excellent examples of structural interventions that are simple to do. Really quickly, again, the cue for a question, and it's hashtag WLGH17. So please tweet them. And I know we're lower on time than I thought, so I'm now going to go to Glenda. And I think this is a great segue because you are the first female president of the South African Medical Research Council. As I understand it, a key part of your job, yes, key part of your job is to change the makeup of that organization, how not just who's part of it, but how it functions. Can you tell us how that's been going and what you've tried to do in your tenure there?
Thanks. So I think I don't need this. Thanks. Good morning, everybody. I inherited an organization that was not transformed. and the way we funded medical science in South Africa was not transformed. So despite the fact that there had been male and African male and Indian male presidents, and no one had ever bothered to look at how we fund science in South Africa. And so in 2013, when I came to into the MRC, I did an analysis to see who we were funding. And the majority of people we funded were white men in Ivy League universities. And we then implemented a systematic review and process to change the way we fund people. And creating two streams, early stage investigators versus mid-career scientists. Previously, everybody would compete for the same pot, and so if you were a well-accomplished grant writer, you would just beat the postdoc. And people who went to Ivy League universities had better mentors and were more able to compete than people from historically disadvantaged institutions. And so I created an early stage investigator program and a mid-career scientist program where people would compete with their peers. We also looked at adjusting. So if you were an African female scientist, we would adjust some of the baseline points, as well as if you were from a historically disadvantaged institution. These grants are internationally peer-reviewed. We follow an NIH system, so we follow meritocracy. And just to say, just in this one program, going from the majority of white men in Ivy League universities getting funding, I can say that the majority of people that get funding now are Black African scientists, and 50% women. So we've in 5 years, we've demonstrated it's just so beautiful when you see the graphs. I go to Parliament and I show them what I've done. It's amazing. And this is scientific excellence. It's about meritocracy. And so I've taught my team. Everybody has talent, and our job is to make that talent show. And we go through lots of processes. So another thing I did was the funding of historically disadvantaged institutions in South Africa. So that's our previously black universities. We had not funded there before, and we created a whole program. We ring-fenced money and created competition to apply for MRC funding, and we took them through a two-stage process about grant writing, and then got the science internationally peer-reviewed. And this program has been incredibly successful. For even in 4 years, we've managed to train masters and PhDs and even publish. So just demonstrating that again, with a little bit of effort and attention, you can make impact in terms of publications and capacity development. South Africa has a feminized medical system, but what we don't see is women in senior categories. I can count on half a hand the amount of female deans of medical schools that have occurred in South Africa. And when we look at leadership, at the leadership level, there are very few women. Although they represent the majority of the health force in South Africa, both in doctors and nurses, when it gets to women drop out because of reproduction, commitment to their families. The way women do business and the way men do business are completely different. So I have a niece who is a surgeon. She's just qualified as a surgeon, and on my way to this meeting, I opened up the newspaper and I saw a study that was just done by the British Medical Journal that said that female surgeons, people who are operated on by female surgeons, are more likely to survive. So that's amazing. And this female niece of mine, she managed to become a surgeon despite having 2 children during her internship, and at the ripe old age of 38, which is very old to specialize. She now is a qualified surgeon, and she did it by having children during her registrarship. And this does show that there are universities in Africa that are quite progressive, where in a male-predominated program like surgery, they allowed a woman to have 2 babies during her reg time, which is incredible. And so, I do think that there are wonderful programs, and that women can become surgeons, and they can have their babies while they have their reg time. The other thing that we also need to do is we have this what we call early stage investigators, and I note that we have a cutoff for both men and women at the same age, and that's discriminatory because women have to do a lot of things before they can become scientists, and women only become scientists or researchers about in their 40s, and when they're 45 onwards, because they're specialized, they've had to have their children, and then they can settle down. And so we've changed the age cutoff for early stage investigators for females, so you can be older and start science older. So, I think my job as the MRC president, and I'll be quickly brief, is not only to make sure that we transform who we fund, where we fund, and how we fund, but also that we grow the next generation of leaders. And we've put into place some programs where I've earmarked female scientists, black female scientists in their mid-career, and we've built programs with them and to mentor them and to accelerate the development, because my job ends in a year's time, and I need to be replaced, and we need to find people, females, black African females that can replace me and continue the legacy of transformation and making sure there's diversity in funding.
Thank you. That's amazing. And now, last but not least, because I know we're going to get to your questions in a minute, is Afaf, who I know is going to talk about a very special role that nurses play in this.
Well, I am the token nurse on this panel. But as a token nurse, nurses always think about the perspective of the people we are serving. So I thought about why gender matters, which is really ponder that question. And there are 4 compelling reasons why gender matters, starting with that women are confronting lots of major health issues and continue to do that. Secondly, that the majority, what I'm going to speak about, the majority of the health care is provided by women. And this was mentioned before, and we'll keep remembering that. The third point that I'd like to say that is very compelling to why gender matters is that women leaders are undervalued, unacknowledged, and undercompensated because they are women. And the fourth reason why gender matters is because of women's ways of knowing that need to be interjected in global health. So I'm going to speak about just 3 of these very quickly because I know about time. So first of all, I want to remind us about what's happening with women out there. Lots of things in their life really puts them at risk. Marriage puts women at risk. 3 women are killed daily by an intimate partner. 60 million girls are married as children. 1 child marriage happens every day somewhere in the world. So we have to remember why gender matters. Public space is not a safe place for women because it's designed by men, mostly, who do not think about protection and safety of women. In different countries, women are unsafe in the streets. 89% of women in Brazil get assaulted on the streets, 86% in Thailand, and 79% in India. So that's women as productive beings, but also women as reproductive beings face a lot of risks. Every 2 minutes, a woman dies still in childbirth. I really want you to think about that. Just think, 700 to 800 women die in childbirth, hemorrhage, hypertension. 60% of them is preventable. And it's preventable if we have the right workforce there to help them, health workforce. 99% of abortion deaths are due to unsafe abortions. Not because of the abortions, unsafe abortion. And we are not immune in the United States. Our maternal mortality rate is increasing by the day. Right now, it's 26.4 out of 100,000 births. In Finland, it is 3.8. We are the lowest in the developed world. And we must not forget the 200 million women who have been circumcised in 30 countries and continue to be circumcised. So gender matters because women are vulnerable and at risk, and we must never forget that. But also gender matters because women are the majority of care providers. 75% or more of the care is provided by midwives, nurses, and caregivers. I want you to ponder that number. And 90% of those are women who are also vulnerable because they face the same risks like everybody else. And for the focus of this conference, these women who are the nurses and the midwives and the caregivers really don't have a voice. And they are not groomed for leadership. They don't sit on the policy tables, and they are forgotten. Why? Because of disciplinary oppression. So if we think about gender oppression, don't forget about disciplinary oppression that happened for nurses and for midwives for so long. Now, how is that manifested? Just look at the number of nurses and midwives in WHO. Today is a very important day. Finally, after we struggled so hard, we have a nurse scientist, a nurse professional in WHO appointed yesterday. Wow. But look at the policy tables, look at the hospitals, in your hospitals, and find how many nurses are on the hospital boards when the majority of the care is provided by nurses and the majority of the workforce are nurses. So, which brings me to how leadership is defined. And I think that's the question that we need to ponder. I think it's defined from a masculine perspective, and I think Anya might have said that, that it is defined in a way that, that does not include the fantastic work that global nurses have done in the world. Just think, if you go somewhere and find on the podium, all the nurses who are on the podium are women, and they are the leaders, they are the deans, they are the ones who establish the programs. The programs I graduated from University of Alexandria in 1961 was there. It was the very first baccalaureate program in the entire Middle East and entire Europe. Who established it? It was established by global nurses who left their homes from different parts of the world to establish that program. So I guess the point I'm trying to make is that we do have a lot of female leaders. We do have a lot of women leaders, but they are representing nursing and midwifery. But because of the way we define leadership, global leadership, we don't think we have enough women leaders in the world. I think we need to take the model. I think leadership has been defined in terms of medicine and in terms of deans of medicine and in terms of a discipline of medicine. And when we expanded it a little bit, we added economists and we added lawyers. So I'm here to ask you to add the nurses and the midwives and take that model of the biggest force in the global health has been nurses all over the world. And we need to remember that.
Wow. Thank you all. So we, of course, have very little time for questions, and I'm hoping that there'll be other times today where we can have dialogue. But let's take 2, 3 maybe questions. And are there any from that have been tweeted in from our people watching? There is, yeah, okay. Grab a mic, and if there's others that want to get just 1 or 2 people that might want to come to the mics in the meantime, we'll take your questions and then we'll wrap up.
Great, so this question is from Women in Global Health. They're asking how to get major donors or investors, i.e. Gates Foundation, for global health to link money to gender equality in all of their work.
Well, first of all, have passion about it. Yeah. Have passion about it. And then, of course, somebody said, let's not use data. I think the data are very important and compelling. No, you said it's more other things is important.
Well, I think you need social. We need to make it a prescription. You need 50% of all grantees to go to women. So I think we need to do social engineering. We need to have positive discrimination, as we heard from Rwanda. Is that we need to say that half of the grantees should be female.
If I can also add, is that I think that donors have an enormous opportunity to make a contribution, particularly in areas that are not the vertical programs. If we look, again, I'm going to make a plug for universal health coverage, where we look at the health system and all of its components, and that they don't wait so long. It's been a missed opportunity many times, and we can't miss it once again. We won't be able to really address violence against women, reproductive rights, and all of there's been huge, recently great funding, and I applaud donors for that. Let's not forget the health system and ensuring that last 5, 10, 15%, the most vulnerable women, are accessing services. So just to put a plug there for this great opportunity that donors can play into.
Very quickly, because I only have one more question.
Does not mean the same in every country. In some countries, equal opportunity means don't worry about what's below the chest, you're all the same. But in Africa, as my colleague said, equal opportunities include both men and women. So sometimes we have to listen to each other. Listen to the Western world, listen to the Sub-Saharan world as well.
Can I say something? So we established a Center for Global Health Women's Research at the University of Pennsylvania, and it was established all through philanthropy. It wasn't the big organizations, but just presenting the data about what's going on in the world for women have been the magnet to bring lots of funds for this center.
Great, thank you. And I think we have time for one more question. So please just let us know who you are.
My name's Joya Mukherjee. I'm an associate professor at Harvard and also chief medical officer of Partners in Health. And my question is to follow up on your excellent presentation, because I see that if we think about the kind of leadership that women have, which may be, in my opinion at least, around caring and around community building, that is not valued and is increasingly less valued by white patriarchy that now should have an MBA and do this kind of management, which is a very top-down patriarchal style of leadership. And so I see that from both the NGO world and in academia. So I just, in McKinsey's, and we were talking on the bus a bit. So how do we break through that? Because we could co-opt it, we could go that way, or we could say, actually, the reason women, patients do better with women surgeons is probably about caregiving, not about management.
Yeah, you need, women leadership is different to male leadership, and sometimes that's why women in leadership struggle, because their peers are male, and sometimes they set you out to fail. But I do think that that civil society and women lead often the changes. And in South Africa, we have a saying, if you strike a woman, you strike a rock. And women have to work with each other to ensure that our countries are rid of people fleecing coffers and men being corrupt and stealing our money. And so as taxpayers and as members of society, we must be outraged about the practices of men leaders.
So I think we are just out of time. Yeah, please, real quick.
Let's remember, skills and papers sometimes don't equal to the same thing. So it's good to have papers, but sometimes skills are more important to get a job done. So let's look at how the job can be done as opposed to how many letters you have after your name.
Exactly.
Thanks. And please join me in thanking everybody here. Thank you.